There are a lot of bones to learn, those 206 bones of the body. And what we go over in lecture is just kind of the tip of the iceberg, what you have to learn in lab. So realize these would be, what we have here would be the things that I would hold you responsible for an exam. So keep that in mind. That's why it's been simplified for you, because there's so much material that we could actually give you in an exam, and we're just kind of simplifying what we do with the bones. We know there's 206 bones of the body. We know that we divide them into two categories, axial and appendicular skeleton. And we started talking about the skull, which is the most complex bone of the body, and it's 22 bones, two sets, cranial and facial. 8 cranial, and therefore, because there's 22 of them, 14 facial. So let's finish up with the cranial bones, and then we'll go on into the facial bones. So we talked about the frontal, we talked about the parietal, and we talked about the occipital. Now let's talk about the last of the external bones, ones that predominantly locate externally, the temporal bone. And in our notes here it says part of the lateral aspects of the skull, check. It has a squamous or thin portion, and that also will have a process that forms part of the zygomatic arch. And so I'll change my color here, see if it'll work. And so this is the squamosal portion, and this is the, actually I'm going to go back to black, squamosal portion, and then this process here is the ZP, the zygomatic process, correct? On the inferior surface of the zygomatic process is an area called the mandibular fossa. And so when they're talking about that, the mandibular fossa is right there with that hole. And it's obviously on the other side. So even though my writing is obscuring it, you can take a look on the opposite side to find that. There is also a portion to the temporal bone. We have a squamosal or flat portion, and then we have a petrous portion. And the petrous portion has a tympanic region as well as a mastoid region. So the petrous is that bony, hard thing, like petrified rock. And so when we talk about the petrous portion, what we are referring to here is, remember, the mastoid process in this area, and then the tympanic region is referring to all of that portion of the bone. So the largest part of the petrous portion of the bone is actually internally located. The mastoid process, as you will learn, is a very important attachment site for various muscles of the neck. Now we're going internal, and so we're going to take a look at two bones that are predominantly internal here in the skull, the cranium, and that's the sphenoid bone. And you know the sphenoid bone is the most complex bone of the cranium and has a lot of things to identify on it. For us, we just want to make sure that you know that it's part of the cranial floor, has a bit of a butterfly shape to it, and has openings for the optic nerves called optic canals. And the canal is to imply that there is some length to this hole or foramen. Also, we have a hypophyseal fossa, which is the depression for the pituitary, and when we take a look up here, this area right here is the hypophyseal fossa for that. Another internal bone, it's predominantly internal, is the ethmoid bone, and that's a very, very delicate bone. And that bone is like, I actually liken it to a butterfly. And you have to handle it very carefully if you actually have a real ethmoid bone. But because it's been handled not so carefully over the years, it's hard to actually recognize it as the ethmoid bone. So we got a plastic model, and I don't know if you have appreciated how crude that plastic model is compared to what remains of the current ethmoid bone. You just can't get a plastic specimen of that bone to actually do it any justice. It is located right here when you're in the cranial fossa, the anterior cranial fossa, and it has an upward projection called the crista galli. And the crista galli is rather triangular in its appearance when you take a look at it from the side. And that is the attachment point for our dura mater. And so outer brain coverings, and they're referring to the dura mater for that. Off to the side, Evidently, our anatomists like to play cribbage. And off to the sides of the cristagalli are these areas where there's a bunch of little holes, and they call those areas the cribriform plate. And so off to the side are the two cribriform plates. There is a perpendicular plate, but that is nasally located, so it's not going to be here where the cranium is. It's actually going to be inside the nasal cavity. And it indeed forms a portion of the nasal septum, and we're going to see that in just a moment when we take a look at a sagittal section. Sutures, as you know, are the immovable interlocking joints that connect the skull bones, and there's just 4 you need to memorize. The coronal suture, like a crown between the frontal and parietal. The sagittal suture, which is in between the parietals in the midline. The lambdoidal suture, which is between your parietals and your occipitals. And then the squamosal suture, which is the squamous portion of the temporal bone, and then the parietals. Advancing to our facial bones, again, there are 14 of those, and we have a few that are singular. The mandible is one, and we refer to the mandible as the jaw, and it is indeed the largest and strongest bone of the face. So keep that in mind, that we're now actually referring to bones of the face. It does hold teeth, so does the maxillary bones, and the maxillary bones hold the upper teeth where the mandible holds the lower teeth. The maxillary bones indeed are fused along the midline and form the anterior portion of our hard palate. And so when you actually take your tongue over your hard palate behind your teeth, you're pretty much feeling all maxillary bone, because the palatine bones are the very back aspect of it, and sometimes you try and do that and you might cause yourself to gag. But the anterior portion of the hard palates are maxillary bones. Zygomatic bones are referred to as your cheekbones, and then the nasal bones form the bridge of your nose, and the lacrimal bones are lateral to the nasal bones and about the size of a fingernail and located in the medial aspect of your orbit. The palatine bones are odd little bones. They are also part of the hard palate, but they're posterior to our maxillary bones and form the last third of the hard palate, if at all that much. There is a bone that's kind of odd. It's a nasal concha. There are actually superior, middle, and inferior nasal concha, and this is listed as a separate bone because it actually is kind of floating around there and held in place by CT and mucosa. So the inferior nasal concha arises from the lateral walls of the nasal cavity, and just to point it out, it's this guy right there. And so the other guy that you see is actually a middle nasal concha coming off of that aspect. So the nasal concha come off of the lateral aspect of the nasal cavity. And whenever you go to an ear, nose, and throat doctor, he's obviously going to look up your nose, and he's looking at those nasal concha to see and assess their health. Now the vomer bone is an interesting bone. It's basically a nasal septal bone. And so the nasal septum is the dividing line between our 2 nasal cavities. And so we have 2 bones that make up the nasal septum. We have the perpendicular plate of the ethmoid bone, which is what I wanted to point out. Now we're below the cribriform plate into the nasal cavity, and so there's that nice ethmoid bone right there. The vomer is this guy right here. Those are both bones, and they form that bony portion of the nasal septum. Now we have a septal cartilage anterior to those guys, and what kind of cartilage is that going to be? Elastic cartilage is in only 2 places, right? Yeah, it's going to be hyaline. Remember, I told you, your knee-jerk reflex should be hyaline cartilage first, and then that's what you should think, and then you should then assess, yeah, is that the proper category for that? So our septal cartilage, all the cartilages of our nose are actually hyaline cartilage. And here you get a little bit of a view of the hard palate. Here's that palatine bone posterior to the maxillary bone. The hyoid bone is an odd bone. It's singular also, and it doesn't articulate with any other bone. It is horseshoe-shaped, and you can easily find your hyoid bone. by going to follow your mandible and all of the muscles underneath the jaw, and then go to the back, and then that bone back there that you can move back and forth, which feels kind of weird, at least it does to me. That's your hyoid bone, and it's kept in place by a whole bunch of muscles. And so it's an interesting one and is important in speech and swallowing because it assists in the movement of your larynx or your voice box, which is inferior to that. So your larynx is actually attached to the hyoid bone, the inferior aspect of the hyoid. We're done with the skull. We're moving on. You guys slow me down if I'm going too fast. We're now going to take a look at the vertebral column, and a lot of people call it the spine, and we're not going to do that in an anatomy course because a spine is a sharp projection or process. So if you say spine, say spinal column, and that would be a better way to actually use that word in whenever you're trying to describe the vertebral column. Now, it's an interesting collection of 26 irregular bones. And they are all designed to actually protect the spinal cord. As you will learn when you do the sheep brain dissection, if you haven't already done one, our brain and spinal cord is actually very soft, mushable material. And so we need to actually provide an armor around them to actually protect them, and that's what our vertebral column does provide for our spinal cord. The vertebral column has many components to it. One of the things before we talk about the bones themselves are some ligaments. There is an anterior and posterior longitudinal ligament, and they are anterior and posterior to the vertebral body. And so they help to actually support the vertebral body and the column to reinforce the stability of these very large areas of the vertebrae themselves. In between the body of the vertebrae, we will find some intervertebral discs, and these indeed are cartilaginous pads in between the vertebral bodies. They actually consist of two distinct areas. The outer aspect is the annulus, so annular around fibrosis, and so that is indeed a very nice fibrocartilage collar that is designed to act like a girdle or limit the expansion of the inner aspect, which is the nucleus pulposus. The nucleus pulposus, nucleus inner core, is indeed a gelatinous center that is there to actually provide what I call springiness. So it gives you elasticity and compressibility. So you can put weight on it and take weight off, and it allows those intervertebral discs to actually have that springiness component. So they're really great shock absorbers because of that. Now, also because of its construction, one of these things actually contributes to what is called a herniated disc. You've heard of herniated discs, and they can be quite painful for people. And it's not typically that the pain is in the area of the disc herniation, but it's in the area of the nerve that's being pinched or compressed by the herniation. And so what material here is herniating? The nucleus pulposus. And so with this fibrocartilage collar, it's not necessarily dense irregular CT, because if it was irregular CT, it would have less of a chance of actually causing a rent or tear in it. And because of the placement of our anterior and posterior longitudinal ligaments, this will also restrict where herniations occur. So the herniations are going to not occur on the anterior aspect of the vertebral body and the intervertebral disc, or the posterior aspect of the intervertebral body or disc. So it's off to the side, and that's important because that's where our nerve roots come out, or the actual spinal nerves come out. And that's why you actually have the pain, because it is truly a pinched nerve by that herniated disc. Let's go ahead now and take a look at the general structure of a vertebrae and realize we are looking here at what they call a stereotypical vertebra, but this is a stereotypical vertebra for a thoracic vertebra. And there are certain things that tell you it's thoracic right off the bat. But first, let's look at the general structure. So here is the body. It's also called the centrum. That is the weight-bearing portion. It's kind of described as disc shape, and it corresponds with our intervertebral discs above and below them. And this is anterior. And so the arch is a posterior structure. This picture makes the arch look like it's only a half-sided arch. You have to realize it's a two-dimensional drawing of a three-dimensional structure. And so the body and the arch together make up the whole, which is the vertebral foramen. And this is where the spinal cord is passing through. Pedicles are like your feet, and you get a pedicure, right? So pedicure, pedicles, your feet, and this is where the arch stands on the body. So in our notes here it says at the base of the arch. And so what they're talking about is really this attachment point of the arch to the body. That's the pedicles. And then processes are our bony projections. And we have a singular spinous process poking out posteriorly, and we have two transverse processes which project laterally. So here's our spinous process, and here are our transverse processes. All vertebrae have articular surfaces because they articulate with something above, a vertebrae above, and a vertebrae below, unless you're at the very top or at the very bottom. And so in this view, we have a superior articular process, so that means we are looking at this from a superior view. On a superior articular process is a facet. So we have two superior articular processes and two superior articular facets. Because remember, the facet is actually this little flat, smooth surface that actually helps to provide a joint. The inferior articular process we can't see because we're looking at the superior view of this. We'll take a look at our next picture and we'll be able to pick it out from here. And then we have intervertebral foramina. Foramina is just a lot of little holes which allow for the passage of our spinal nerves. So here's our anterior longitudinal ligament, and back here is our posterior longitudinal ligament. And this is our intervertebral foramina here, and obviously up here. We have our superior articular process right here and right here. And then the inferior articular process, I'll just go ahead and erase that one. The inferior articular process is right here. And remember, these processes have facets, so you have to mention the facets whenever you actually, if that's one of your tasks. And then this is a nice view of our intervertebral discs with the annulus fibrosus and nucleus pulposus. There are a lot of ligaments associated with the processes of the vertebrae too, and we're not going to go over those. We're next going to take a look at the 5 regions and also consider divisions as well as curvatures of the vertebral column. When you are in utero, when you're inside the uterus or the womb, you are typically in a certain position, and that position is called the fetal position. And so when you think of the fetal position, you think of it kind of like a C, right? Head up here and hips back here. Oops, let's not make their foot go backwards. There we go, head here and feet here. So that's the fetal position. And so that's what we're talking about when we talk about curvatures. We've got some primary curves and we have some secondary curves. The primary curves are one that you acquire in utero when you're a fetus, and then the secondary curves occur after you're born. And so one of the things that's nice about floating around in water is you don't have to worry much about gravity, correct? And the amniotic fluid helps you with that. So the primary curves, we're going to talk about cervical, thoracic, lumbar, and sacral. We're not going to talk about coccygeal because that's kind of just part of the whole process. Which curve in these areas of the vertebral column is actually established when you are a fetus? Cervical, thoracic, lumbar, or sacral?
Thoracic.
Thoracic for sure. Absolutely. Thoracic. What other curve? Because there's another one that's set while you're in utero of those four. Sacral. Okay. And so we have these two curves that are actually going in the same direction that we need to counteract. And that's why the other curves are acquired secondarily, because we counteract them because of gravity. And so which of the other two curves do we counteract first? And then this is acquired secondary curves. Which ones do we acquire first of the other two? Cervical, because the kid has to learn how to lift his head. Once he can learn how to lift his head, then that cervical curve starts to actually get set. And if you ever take a look at somebody's x-rays from a lateral aspect of the vertebral column, you indeed see one going this way for cervical, thoracic going this way, and what do you suppose the lumbar does? It goes in the opposite way, and then you have your sacral. And so we have all these different curves that are actually we acquire because we have to stand erect or upright. And the reason the lumbar forms after the cervical is you have to lift your head up first and learn how to control your head and neck, and then after a while, mom and dad are happy that you're rolling over like a puppy dog. You know, they do that, they love it, you know. And then they start sitting you up in the corner of the couch, right? With all these pillows around you, and you go like you're a Buddha. You know, you can't quite handle it. But then you're able to actually sit up on your own, and that means then you have acquired that lumbar curve. And once you have acquired that curve, then you can acquire the next thing that your parents love for you to acquire until after you've acquired it, and that's how to walk. They love to tell everybody he's walking, and then they are no longer happy after a while, because not only is he walking or she walking, that means you have increased mobility to explore the world, and the parents have to keep up with you. And there's enough to keep up with all by yourself as a parent. Okay. So let's take a look now in a little bit more detail at the 5 regions. Cervical is referred to as the neck region, and we have 7 vertebrae, and typically that's C1 through C7 is how we actually depict that. Cervical vertebrae have some unique features that you should make sure you know about in lab before your eval comes. Their spinous process is bifid, and in the transverse process they actually have a foramen, which the other vertebrae do not have. And so that foramen is going to be important for a blood vessel that's helping to supply blood to your brain. But C1, and as you can tell, here's the foramen that I'm referring to in the transverse process. C1 and C2, though, are actually completely unique of all of the cervical vertebrae. And they have special names, too, for them. C1 is our atlas, and C2 is our axis. And that tells you a lot about what they do. Atlas held the world on his shoulders, and so C1 was given that name, and axis is something that you can actually spin around on. So that's why they gave that name to C2. And we'll take a look at some of the special features of these. C1 is unique in that it has no body and it has no spinous process. Instead, we talk about the anterior tubercle and a posterior tubercle. These superior articular processes are mounted on lateral masses. and they articulate with the occipital condyles. We're going to talk about what is the mechanism of action then with the head on C1 in a moment. But let's do C2, which is our axis. Axis has this unique projection called the Dens or odontoid process. This actually projects upward into the foramen of C1 and allows C1 to rotate on this. And so this Dens or odontoid process is actually found up here. And some say it's the lost body of C1. And there is a super strong ligament across from each lateral masses that help to keep it in place. And so when you think about the action of the first vertebrae on the second vertebrae, it's going to allow you to do what when you're talking to people? Say no, right? It's going to cause you to allow those side-to-side movements or no. So then, since C1 on C2 allows for that type of action, what do the occipital condyles allow on C1? It's like a little bit like a rocking chair. And so those occipital condyles are like the rungs of a rocking chair, and then our superior articular process and facets are actually like a little bit of groove in your carpet, in which they actually allow the rocking back and forth. So those are our cervical vertebrae. And now let's take a look at our thoracic vertebrae. And our notes say we have 12, absolutely. And they are indeed like our typical vertebrae, and they have costal facets for the ribs. So the costal facets for the ribs are in various areas. We have them on the transverse process, and we also have them, because that's what we actually can't see it from here, but we actually see it over here. And also we have another facet that they call it a demifacet on the vertebral body. So those are facets for rib contact. And so that will form a joint, and that's what articulation is all about. When you take a look at the thoracic vertebrae, this is considered an oblique view. They have a tendency to make themselves look like giraffes to me. And then when we take a look at the lumbar vertebrae, this is also, again, another oblique view. And I think they look like moose. In the southern areas, they actually say Scotty dogs. And I think they look like what I've seen in this area, and they look more moose-like than they do Scotty dog-like. I never saw the Scotty dogs when I was down south looking at these things. It's, you know, it just doesn't look like a Scotty dog to me. I'll stick with the moose view. We typically have 5. Do we always have 5? How many did you guys, what was the number that you found in at least one of our skeletons in lab? 6. So if there's going to be variation, this is the area of variation. But the variation is not very common because our notes say we have 5. So there is occasional individual that will have an additional one, but that is not the norm. But if you are going to have a variation, it's going to be in the lumbar area. And those individuals will be easier to kind of go, I wonder if that person has an additional lumbar vertebrae because what will you notice about their waist? They're going to be very long-waisted, right? And so those individuals indeed will have really long waists. There's an actress that I saw the other day that I go, I wonder if she has an additional lumbar vertebrae. She's a redhead that was on Game of Thrones. She was a wildling. I can't remember. Yeah. If you there was I saw Vin Diesel. Yeah, Rose. Yes, I saw a Vin Diesel movie the other day with her, some sort of witch hunter movie, and it was really funny because I looked at her. Boy, she's got a really long waist when you look at her legs. It makes me wonder about that. So you can actually, with this kind of knowledge, look at people and you go, I wonder about that. We also have an interesting skull in the lab that's missing something. A suture. And what suture? Sagittal suture. And when you take a look at that skull, the head, that's a full-grown adult skull. And the head is really long. And I know that we have somebody here at NIC that has that type of a skull, and I've never told them that, because they've never taken A&P from me. So it's just like, well, really long head, okay, I know what you're missing, So it's kind of fun to know these little things because you can just go, I know something about you that even you don't know about you. And you can share if you want, but typically it's best to just say nothing. Because then you'll make them very nervous that you know more things about them that they know about themselves. And then they'll want to know, is it true? And how are they going to find out? X-ray's the best. Okay. Now, our notes say here, indeed, they are the largest and therefore the strongest of the vertebrae, because size does matter. And why would it be so important for them to be so large and so strong? Yeah, this is truly supporting everything superior to that. And so you remember we have our axis and we're working our way on down and truly everything that's up above is the weight is being increased with each step down on the vertebral column. And so these guys are indeed more coarse in their features because they need more strength. Now, have you guys heard of vertebral compression fractures? What part of the vertebrae would probably end up being compressed and therefore fractured? So when you hear that, now think about this, because what you would have to have in order for a fracture to occur, that means, because it's called compression, where is the compression forces exerted? The body. And so a vertebral compression fracture, just now thinking about it, walking through that, you would actually know that they're talking about the vertebral body. And when people have a compression wedge and it actually ends up making it a bit wedge-like in that compression, do you have any idea what kind of position they will be forced to assume as they have that compression? That's right. They will have that thing that we can sometimes call kyphosis. You'll learn these terms later on, but they'll be hunched over, and people will want them to stand straight up. Can they? And see, they can't, because that has actually caused things to actually shorten anteriorly, and they cannot actually straighten up like they used to be able to. And so it's like a bony deformity and cannot be actually altered for them. So again, diet, exercise, and sun.
So the fracture can't heal?
The fracture will heal, but it will heal as a compression. Yeah. And some of them are painful and some of them are painless. So it just depends upon how you're constructed. Now let's go to the sacrum. It is 5 vertebrae that have been fused into one and has a superior articular process. It shouldn't say processes, it should say process, because it's referring to this area up here, because it's going to articulate with L5 for the standard lumbar vertebrae number. Now, we have ala. Ala are wings. Do you guys see the wings now? When I say ala are wings on this sacrum? And so these are the wings right here. And your nose has ala. Can you figure out what the wings are in your nose? It's what sometimes people can flare their nostrils. They're flaring their little ala, their little wing. So ala is Latin for wing. So when you run across it, that's what it's referring to. And it's important that you actually realize there is another name for the surface on the backside, and it's called auricular. Auricular is for ear. That's an ugly ear is all I've got to say about that. So we have auricular surfaces. On the posterior ala that articulate with our ilium. Is it I-U-M or E-U-M? I-U-M. Because E-U-M is intestine or enteritis. So, you know, because you would think I should be intestine, so you need to think the Latin term, enteritis, and the E is enteritis for intestine, ilium. And we call that ilium, it actually belongs to a part of our, all of this joint here is part of the pelvis, which is a structure. And it has a special name. It's called the SI joint. So when they talk about the sacroiliac joint, that's what they're talking about. They're talking about where the ilium actually articulates with the sacrum, and that's a posterior aspect. And the final component of our vertebral column is the coccyx, and they are 3 to 5, and that is a considerably variable number on that one. Bones that are fused into one, and we typically call it the tailbone. One of the things, too, I want to point out with our picture here of the sacrum, remember apex. You used to think apex was the top part. Now I want you to think of apex as the pointy part. As long as you think of apex as the pointy part, you will be fine. Because there's also an apex of your heart, and it's also inferiorly located. So it's the pointy part of your heart. Let's take a look at that structure called the bony thorax, also referred to as a thoracic cage. And this is going to be your sternum, your ribs, and your thoracic vertebrae. We all know our sternum as our breastbone, so it's the anterior midline of our thorax, and there is an area called the manubrium, which is the upper portion of the sternum, and then there is the body. And where the manubrium contacts the body, there's actually a sternal angle. And this is an important landmark because this is always where you can find or start counting your ribs. Your ribs. Your ribs, because this is where the second rib always actually articulates, is at this sternal angle. So second rib attaches here. And our picture down here is indeed showing the second rib and its attachment at the sternal angle. Now we have 12 pairs of ribs. Do women and men have equal number pairs of ribs? One of the things I want you to think about, and it's also I want you to know, I think it's A-okay to be wrong, because I can't tell you how many times I've been wrong about things. So even when you're wrong, you're learning from that experience. So I want to ask you, if the ribs are different in men and women, who has more? Men? Why would women have less?
More space in the house.
Because in the story, the biblical story, Eve came from a rib taken out of Adam. And Adam was kind of created in man's own image. And so men had how many ribs before that rib was taken out of Adam? He had 12. So how many ribs would Women have. $12. The answers are really the obvious answer, not what you're trying to make it. See, this is the problem. I have yet to figure out how to help you guys. The answer is the easy answer, not what you are trying to make it. You're trying to make it a different answer, because I honestly try to lead you along to the very simple answer option here. Biblical teaching is that Eve came from a rib from Adam and was formed in a similar fashion, but obviously differences. And if you actually looked at all of the skeletons and counted all of the ribs, every single one of them had 12 pairs. The thought then would be well, then Adam would have less ribs than Eve because you took a rib out of Adam, right? But if you took a rib out of Adam and then he had a son, why would his son have less ribs? Because you surgically removed his rib. That would be like saying if you cut your thumbs off, you're going to have sons and daughters without thumbs, right? So one of the things that is important for you to learn and also to teach your children is you tell your kids certain stories that they can understand at that stage in their life, right? And then you never ask them to rethink those stories, again, as they get older and more knowledgeable. And so that's all I'm asking you guys to do, is I'm asking you now to rethink the stories that you were taught when you were a child, and that the conclusions you drew as a child were a child's conclusion. And now you're adults, and now you can actually understand the more adult story of the story. And so that's one thing that you always have to realize. What you learned as a child was because of your child mind. And as you get older, you should actually start to have certain realizations that, well, it's not really that way at all. Because I know you guys aren't telling your kids the straight up truth about where babies come from and how it happens. Because would you tell a child all of those details at this stage in their life? That's 6, 7 years old. Typically, you tell them only one thing, and then you hope they stop asking. And then later on, when they get older and ask again, then comes the challenge of how you're going to answer the question when they get to be teenagers or preteens. Because you never want to tell your kids too much. You want to tell them just enough to satisfy their curiosity and hope they leave you alone with those stories. So let's take a look now at the articular aspects of the rib. So indeed, we have the head of the rib articulating with the body. And then we actually have this area called the tubercle of the rib that's articulating with the transverse process of our thoracic vertebrae. We actually divide our ribs into two categories. We call one set true ribs and the other set false ribs. That makes it kind of easy true-false questions. True ribs and false ribs. And one reason that we call the true ribs is that there is a bone in the back and a bone up front that the ribs are essentially attaching to. The false ribs are not going to have one of those two attachments. And so let's take a look at our true ribs and realize they're called vertebrosternal. So we have an attachment that's vertebral, and we have an attachment that's anterior and sternal. Of our false ribs, we have one set of false ribs called vertebrochondral. So that means we're attached to the vertebrae posteriorly and to a cartilaginous material anteriorly. That could be the only way to attach. And then we have ones that are just called plain old vertebral, which means that they only have one attachment site, and that's posteriorly. So let's take a look at our true ribs, and they are ribs 1 through 7, or the upper 7. And so here's 1, here's 2, which remember the sternal angle always tells us where to start with 2. Here's 3, 4, 5, 6, and 7. Even though this bar of what type of cartilage? Hyaline cartilage is very long, you can tell it is indeed originating from 7 and making an attachment on the sternum. That's why we call it vertebral sternal. The next 3, 8, 9, and 10 are called vertebral chondral because their bar of hyaline cartilage is attaching to the one bar of hyaline cartilage up above. So number 8 is attaching to hyaline cartilage, number 9 is attaching to hyaline cartilage, and number 10 is attaching to hyaline cartilage. So they call those vertebrochondral. And so vertebrochondral are the next 3 pairs, so that's 8 through 10. And then vertebral are also called our floating ribs because they have no anterior attachments. And so that's 11 and 12. We're now into our appendicular skeleton, the things that we attach to the axis. And we have an upper extremity and a lower extremity. And the upper extremity is attached to the axis via the pectoral girdle, also known as the shoulder girdle. The lower extremity is attached to the axis via the pelvic girdle. So the girdles are the ways that we attach the extremity or your limb to the axial skeleton. And the shoulder girdle or pectoral girdle is interesting in that it is 2 bones, the clavicle and the scapula, and it is an exceedingly unusual arrangement that these bones have with the head of the humerus that allow for the wide variety and range of motion that you actually have with your upper extremity. And let's go over the 3 reasons why the upper extremity has such fantastic mobility. What's really strange is that we actually only have one small articulation point to the axial skeleton, and that's the sternoclavicular joint. So right here, that's the only actual attachment to the axis. And it's a really small attachment. The scapula is going to move freely over the posterior thorax. And remember, the scapula has 3 fossas. We have the supraspinous fossa, the infraspinous fossa, and the subscapular fossa. Which one is anterior? Subscapular fossa is anterior. And it's big and flat. And in the subscapular fossa, you guys are going to learn, there is a muscle called the subscapularis muscle. So that's why you have to actually learn your bone names, because a lot of our muscles are named for where they're located, like the temporalis muscle. And subscapularis muscle is named for the subscapular fossa. And so we have this really big, flat fossa here that is got a muscle in it, and it's going to glide over the posterior surface of our thorax, or thoracic cage, and go all over the place, as you guys already know. And we have, in addition to that interesting aspect, we have a very shallow socket for a ball and socket joint here. And so this glenoid cavity isn't deep, it's very small and shallow, and the head of the humerus is huge when you actually compare it to that. And so if you put your fingers on your sternoclavicular joint, and then raise your arm up and move it anteriorly and posteriorly, that just is a demonstration of the very weird dynamics of the range of motion that you actually can get with that joint. Now, the scapula is attached to the sternum because the humerus is attached to the scapula, right? And the scapula is attached, not to the sternum, I meant to the clavicle. The scapula is attached to the clavicle at the AC joint, a acromioclavicular joint. So we kind of have this tandem connection that also helps promote this very wide range of motion here. So in our notes, let's see here. Socket is shallow and poorly reinforced, absolutely. Scapula moves freely over the posterior thorax. Nice flat surface of the scapula is anteriorly positioned for that movement. and we have that sternoclavicular joint. And so what we actually have here is a lack of restriction of movement. So our movement is not really restricted. All of those things combine for wide range of movement or motion that you actually have with your upper extremity. There's not too much that actually moves like that other than maybe your thumbs. So let's take a look at the clavicle. As we know, it's also called the collarbone. Sternal end is the only attachment to the axial skeleton, and then the acromial end articulates with the acromion of the scapula to form that part of the AC joint. Scapula is also referred to as shoulder blade. It indeed has a very shallow glenoid cavity for the head of the humerus, often referred to as the shoulder joint there. And the acromion is indeed the lateral end of the scapular spine. So it's far off to the lateral side that articulates with the clavicle and contributes its aspect to our AC joint. So the shoulder girdle or pectoral girdle is an unusual construction. Now let's take a look at the bones of the upper limb. And first off, we'll deal with the arm. And its bone is called the humerus. And we also call this area between the shoulder joint and the elbow joint the Latin term brachium. Okay, so don't forget this is also, we're discussing the brachium. Because where would the brachial artery be located? Right along with the brachial bone. Okay. Now, with our humerus, the head is proximal, so that means up here, associated with the girdle. We have two tubercles. We have the greater tubercle, which is laterally placed, and the lesser tubercle, which is medially placed. And indeed, these are important attachment sites for rotator cuff muscles. And so when somebody has a rotator cuff injury, if they have some inflammation of these tendons, they'll have some tenderness in these areas of attachment. In between these tubercles is the intertubercular sulcus, and it is often referred to in the medical field as the bicipital groove. And so this is where the tendon of the long head of the biceps brachii actually goes through this. We also have associated with the humerus the deltoid tuberosity, lateral attachment point for our deltoid muscle. And at the distal aspect of our humerus, we have two condyles, the trochlea for the ulna and the capitulum for the radius. And so which one of these two, trochlea or capitulum, is medially located? The trochlea is medial and the capitulum is lateral. Above these condylar surfaces, because condyles are articular surfaces, are epicondyles, and indeed they are points of muscle attachments. So these are areas above the condyles. So the lateral epicondyle will be associated with the radial aspect, or the capitulum, and then the medial epicondyle will be associated with the ulnar or trochlear aspect.
So when they say epicondyle, do they mean there's the condyle and the epicondyle sits on top of the condyle, or?
The condyle sits on the bottom of the epicondyle. So it's a massive area of the bone. It's not just a spot. It's that when you actually take a look at the condyle and then look at the area above it, those are all the epicondyles.
So the epicondyle is proximal.
Epicondyle is proximal, yes, to the condyle for this bone.
Yeah.
Now we're off to the forearm or the antebrachium, and there's two bones here, the radius and the ulna is longer than the radius, and indeed is what's responsible for giving you your elbow. and it is medial in the anatomical position. In the natural position, these two bones cross. And so when you're an anatomist and you're laying out a skeleton, how are you going to lay the bones out so that they stay in place? Side by side, right? And so that's why we actually came up with the anatomical position, because in order to actually examine or put things out together, you know, create a skeleton, you had to put things in a linear fashion, and crossing the bones did not keep the bones in place very well for you. So that's the actual foundation of the anatomical position. The olecranon process. Hit your olecranon process. It's not hard, you know, just hit it with your other hand. So that's that pointy part of your elbow. That's the olecranon process. It's actually pretty darn big, because it has a portion of it that actually will enter the olecranon fossa on what side of the humerus in the anatomically correct position? It's actually posterior. The olecranon fossa is posterior on a posterior indentation on your humerus, because the other one up front is the cornoid fossa, because you actually have that other aspect of the ulna that you need to remember for your bone eval, not for your testing, but for your bone eval. So let's take a look here and let's write a few things in. Olecranon process, posterior portion. It's basically what is most of your elbow. And it locks to prevent, the process locks in olecranon fossa to prevent hyperextension. Even though it's big, proximally, its head is located distally, so it's at the area of your wrist, and has the styloid process on it. Our notes here tell you it plays no role in hand movement. And indeed, it's more of a stabilizing bone. So it's kind of what everybody is attached to. And so if your things are attached to you, you're supposed to be a stabilizing aspect of our antebrachium. And the thing that really is phenomenal in that with hand movement, when we say plays no role in hand movement, we're actually talking about a hand movement called supination and pronation. And so supination is easy to remember. It's what position your hands would be in if you were carrying a bowl of soup. And pronation is the opposite of supination. And so when you supinate, your bones are parallel. And when you pronate, we start to get crossing. And it's actually the movement of the radius that is actually allowing you to do supination and pronation. And the ulna is actually stabilizing the entire forearm. Our radius is lateral in the anatomical position, and the head is proximal. And we have this interesting ligament. The interosseous membrane is a ligament, and it runs in between the radius and the ulna and keeps them attached to one another and allows for that interesting crossing to actually keep things stable and not slipping. Because if you were two bones that were crossing over one another, you could, and if you didn't have something there to kind of keep everything right close to your ulna, that bone could theoretically slip across the length of the ulna, correct? And the interosseous membrane allows for keeping stability of that crossing of those bones in that one specific area. So between the radius and ulna. This is my shorthand for between, B/T. And don't forget the radius, the proximal head articulates with the capitulum. As you can tell, we're working our way down the limb, and we're in the area that's called the hand. And when we say hand, we mean wrist, palm, and fingers or digits. So that's your hand, wrist, palm, and fingers. And so the beginning of the hand, the more proximal aspect of the hand, is the carpus or carpal bones, and they are also referred to as wrist bones, and we have 8 and 2 rows of 4. And that's all you have to know. You don't have to know all the names for the exam. The metacarpal bones are what make up our palms, and they are numbered 1 through 5, with the thumb being 1 and the little finger being 5. So there's 5 of them. And important about the metacarpal bones is that the head is distal and the base is proximal, and then of course it's a long bone, so it has a shaft. And we know the distal head as the knuckles whenever we have a clenched fist. So those are the head of our metacarpal bones. Our phalanges are our finger bones, and I see that we have a typo there. So PH in my notes, I don't know if your notes have that typo too, Phalanges. So phalanges are finger bones or are digits, and each digit will have 3 phalanges except for digit 1, and digit 1 only has 2, and we would call that a proximal and distal phalanges. For those that have 3, we have proximal, middle, and distal. Covering the skeleton, had a quick clip here. We're coming up to the pelvic girdle, and so you have to memorize all these different names, and definitely you've got to memorize them so that when it comes bone eval time, you're not confused about your task. Pelvic girdle is also referred to as hip bone or coxal bone or os coxae. They're all synonyms. Pelvic girdle, hip bone, coxal bone, or os coxae. They're all the same. And it is a very complicated bone. And that's because it's actually the fusion of 3 separate bones that you actually were able to identify in the fetal skeleton. And so, again, here's that term wing, ala, and you can see that looks wing-like when you actually take a look at that pelvic girdle. And it is a portion of the ilium, which is a huge portion of our coxal bone. And then you have your ischium, and with your ischium are the ischial tuberosities, and I refer to those as your sit bones, because that's exactly what you're sitting on right now, your ischial tuberosities. And then your pubis is the anterior small portion of the pelvic girdle itself. There are all kinds of names associated with this. Iliac crest, anterior superior iliac spine, anterior inferior iliac spine, and posterior superior iliac spine, posterior inferior iliac spine. Then there's the ischial tuberosity and the ischial spine. So there's so many different things to point out. So the sphenoid bone is the most complicated bone of the axial skeleton, and the pelvic girdle is the most complicated bone of the appendicular skeleton. If you can master those, you've got it made. You're not going to have any problems with the bone evals. If you do not have a very prominent line, what do you know about that person? That's right. They weren't walking around with lots of heavy weights on their shoulders or having to run long distances, because this line is called gluteal line, for example, is telling you that that is one of the attachment sites for one of our gluteal muscles. And so you have a pretty good idea whether or not they had a big butt or not. Little people with flat butts, they have little bitty gluteal lines. You don't really want to have to find it on their own skeleton one day. So those that actually have very well gluteus maximus muscles and minimus and medius muscles will have really nice gluteal lines. These are just You know, if you ever go into anthropology, you'll actually be more interested in some of this stuff. But you can tell a lot about a skeleton by checking out the tuberosities, spines, lines, etc. with them. We are now looking at a structure because we have the sacrum here as well as the coccyx associated with the sacrum. And we have two oscoxal bones. And this creates the pelvis. So the pelvis is a structure. The pelvic girdle is a bone, but the pelvis is a structure. Just like our rib cage or our thoracic cage, we actually have that structure. So it's a collection of bones. So the pelvis is just like that. It is structured. Two coxal bones plus the sacrum. In the fetal skeleton, and also part of your task when it comes time to do bone eval, you have to outline the ilium, the ischium, and the pubis. And the ilium is indeed the largest flaring portion. That's superior. Whenever somebody has their hands on their hips, they have their hands on their iliac crusts. The ischium is what you're sitting on, posterior inferior part, and quite thick because you're sitting on it. It's bearing a lot of weight. Has a thin ramus because a ramus is a bridge or connection to another bone, and has the ischial tuberosities that I like to point out for people. The pubis is the anterior-most portion of the coxal bone, and in between the pubis on either side we have that fibrocartilage disc that is part of the symphysis pubis. Now, one of the things that's kind of helpful is figuring out how to remember where you're going to make your lines, if you have this as a task, for showing the ilium, ischium, and pubis. And so you need to take your pipe cleaner and you need to go across the acetabulum a little bit above halfway and make a line. That's the ilium. And then you need to figure out how to do the ischium. And so then from that, you just make a T. Straight on down. And now you have your ischium and your pubis. And so if you take a look at this bone and you do this little T maneuver, you'll actually see it makes it so much easier to figure out how to show ilium, ischium, and pubis from that aspect. Give it a try and see how it works for you in lab. So this is our pelvic girdle. This is the attachment point. So pelvic girdle is different from pelvis, right? Because a pelvic girdle is a bone and a pelvis is a structure. So one of the things, too, to realize about the pelvis, it belongs to both the axial and the appendicular skeleton, correct? Because it has the sacrum and then it has our pelvic girdle bones. And so sacrum is part of the axial skeleton and the girdle is part of the appendicular skeleton. So it's a structure that is part of both. Now our lower limb is going to be our thigh, our leg, and our foot. And so realize similar divisions with these as we did with the upper limb or upper extremity. The femur is the strongest bone of the body. And so when somebody breaks their femur, that was a lot of force that was applied to it. We have the head proximally, which articulates with the acetabulum of our pelvic girdle or coxal bone. And it has a tendency to bow a little bit medially to try and bring the knees more centered to give you a better balance or center of gravity. And this also gives you better balance. The neck. The neck is the actual weakest point of this bone. And if it's the weakest point of the bone, that means whenever you have a fracture of the bone, this is the more common area that a fracture would occur. And indeed, when somebody says they broke their hip, this is what they're telling you. This is what a broken hip is, a break in the neck. We have greater and lesser trochanters, and these are obviously distal. And, oh, excuse me, I meant condyles. Yeah, these guys aren't distal. The trochanters are very proximal. I was off to the next topic. Greater and lesser trochanters are proximal, and they are muscle attachment sites. Lateral and medial condyles are distal, and they articulate with what bone?
The radius, or the tibia.
They articulate only with the tibia. Patellar notch is an anterior feature and is an indentation for our patella. We're going to go ahead and stop there. We'll be able to easily finish up this next time. And then you'll be having, some of you will be at, no, Thursday won't have bony evals. They have their bony evals on Friday or the following Monday. But this will, hopefully some of the lecture will help you with some thoughts about how to prepare for your bony evals.